and we'll continue with our discussion on professionalism. As you would recall, last week we had discussed about the attributes of professionalism. What is professionalism? Why is it important? And most importantly, we had discussed as to why is it important to teach and assess professionalism, contrasted to the commonly held view that professionalism can be picked up by the students. I showed you evidence to say that it is not always the case. And students lack professionalism as much as they lack the clinical skills, knowledge, and other things. So, if we are not hoping that they would pick up the clinical skills simply by following us on our rounds, then it is unwise to believe that the students would pick up professional behaviors simply by accompanying us on our rounds. Now, one of the major reasons and major problems, if I would say, about assessing professionalism is that professionalism actually comes in various definitions, various models. And my conceptualization of professionalism may be very different from, say, Shreya's conceptualization or Pramod's conceptualization, because we all think of professionalism in different ways. In fact, when I was in some committees deciding and designing the checklists to assess professionalism, the emphasis was whether the student has worn a jean or he has put a tie or his shoes are polished or not. So we start thinking about corporate professionalism or a managerial professionalism rather than about medical professionalism. And so when we talk of professionalism, we have to be very clear that we are talking about assessing medical professionalism. And medical professionalism has its own well defined attributes about which generally there is no confusion or there are no different meanings available. I hope you remember this diagram which I had shown you last time. So, professionalism actually stands on the three bases. And the base of professionalism is found by clinical competence, most importantly, good communication skills, sound understanding of medical ethics. And then there are certain pillars. And what are these pillars? These include accountability, being responsible for your own actions, altruism, putting the interest of the patient more important and above your own interest, excellence, that means striving for giving the best in healthcare, or if we talk in terms of IMG competencies, then it would be a concept of lifelong learning and self-directed learning, and humanism. Interestingly, this model tells you about assessment of professionalism also. So, in other words, if you have to assess professionalism, these are the attributes which you need to assess. And as we discussed last time, you cannot be a professional if you are not clinically competent. You cannot be a professional if you cannot communicate with your patient about or her problem, about the possible interventions, about the outcome, prognosis, and so on. If you look at this model, you would also appreciate that success or failure in practice depends on these attributes: how you communicate, how ethical you are in your dealing with the patient, how up to date you are in your subject area, how accountable you think you are for your actions. Success in profession doesn't depend on your NEET scores, doesn't depend on how many gold medals or how many positions you earned in the university. So it's important. And even from patient's point of view, what he looks for in a doctor, can you communicate? If you're not able to communicate, It makes no difference to him whether you are a FRCP or MRCP or multiple gold medalist or so. Although I'm not promoting quackery, but if you look at it, why are quacks more successful than qualified doctors? Because they communicate well. They can talk to the patient in his own language. Patient understands them, which is unfortunately a problem with medical graduates. If you look at the nursing curriculum, you find they have uh, assessment on communication skills. They are required to give presentations in the ward about communication and health education and so on. But for medical students, unfortunately, we don't have any such mechanism. So we presume that if he accompanies me on the round, he will pick up my communication. They do pick up, mind you, they do pick up. But it is not the ideal things that they pick up. They always tend to pick things which supposedly give them power. पेशेंट को डांट दिया देखा मैं कितना पावरफुल हूँ दैट इज व्हाट दे पिक अप सो देयरफॉर इट इज इंपॉर्टेंट दैट we maintain quality. And one of the key concepts of maintaining quality is that unless you measure, how will you ensure quality? You have to measure to tell how much is the quality, and then only you can take intervention to improve the quality of care. So, with this background, let's move on to medical professionalism. And a few years ago, Rajiv Mahajan and I had actually given this model of clinical competence and medical professionalism. So, what we felt was that integrity and honesty, ethical practice, compassion and altruism, respect for others, or humanism, if you want to call that, self assessment and improvement, reflective behavior, and commitment to excellence. And all this is surrounded by a layer of clinical competence. Because without clinical competence, none of these is meaningful. And without these, clinical competence is meaningless. So they are intricately related to each other. And I'll discuss a little more about it a little later. We've already said that present behavior predict future action. Now, if a student makes false signature on your logbook when you have not even seen the logbook, then quite likely that in later life also, he would probably indulge in this kind of behavior. If a student is rough with a patient, then most likely he'll continue with the same behavior unless you intervene and correct that behavior. And also, most problems against doctors don't relate to competence. When a patient goes to court, consumer court or civil court or other courts, they don't go about that the doctor did not give us the latest antibiotics or the doctor didn't make the correct diagnosis. That's generally not the case. Most of the times the problem is बताया ही नहीं इतना खर्चा हो गया पहले नहीं बताया था प्रोग्नोसिस नहीं बताया ये प्रोसीजर का रीजन नहीं एक्सप्लेन किया those are the reasons actually why most of the problems against doctors arise. In our country we probably don't have that kind of a statistics. Maybe Pramod can pick that up. You can actually take out various CPA cases against doctors and then see what was the major issue in those kind of cases. But from the West, where such documentation is available, it's very clearly visible that the problem against doctors, major 75% or above, actually relates to conduct and not actually their clinical competence. Because patient is not in a position to comment on the competence of the doctors. More so in our country, where level of literacy may not be that high. And don't forget that assessment is the tail which wags the curriculum dog. Even if you don't do anything to the assessment, the simple fact that you are assessing will make the student change his behavior. When he's talking to the patient, you just stand there and watch. Don't do anything. No checklist, no marks, no grade, nothing. Simply you're standing and watching will change the way he communicates with the patient. In fact, on the lighter side, I was once told by somebody that in most of the malls, they only have a dummy security camera. They don't record anything. But mere presence of camera actually changes the behavior of people. They don't indulge in various illegal activities. Now, when you have to assess professionalism, these are the attributes which you need to look for in assessment of professionalism. First, that it should be realistic context. That means what happens in day-to-day practice. So if your practice involves, for example, communicating or educating the patient about healthy lifestyle, then you should be assessing the student on that rather than on his ability to communicate about kidney transplant. That is not the area where he is going to work and he is going to be assessed. So it should be realistic. Secondly, it should involve some kind of a conflict. I remember so many conflicts in my clinical experience over many years. You know, the child is brought very sick, but you know if he is not given treatment, probably is not going to make it. But the mother will not admit because there's no money with them. Now, what do? You cannot pay for every child's treatment, but at the same time, you know that if you don't treat, the child is not going to survive. So these kind of conflicts are there in every healthcare professional's day-to-day work. And it is during these conflicts that your true behavior or your true thought process actually comes on the surface. If you translate it to Hindi, this means duvidha. You know, when you have two ways, you can go this side or you can go that side. And you can't decide which way you should be following. Or if you want to translate it into Sanskrit, in Gita, for example, when Arjun and Krishna were having this problem, then this is called Dharm Sankat. You know, you can't decide whether you should fight or you should just walk away and give the kingdom to your opponents. And that is the time when the best in you comes out and the real in you comes out. Your assessment should focus on specific situations. Don't focus on traits. Don't say, ये बच्चा generally अच्छा है. That doesn't mean anything. Focus on specific situation. When he has to communicate with an angry parent, how does he do it? When he has to declare death of a child or a patient to the relatives, how does he do it? When he has to accept his mistake, he has given wrong injection, he has given more dose, less dose, whatever. Whenever he has to accept his mistake, how does he do it? That is what you should be focusing on. And therefore, the student has to be involved in design and implementation of assessment. You cannot say, mere hisab se, this is the best and this is what I'm going to do. And most importantly, having done all this, you have to give a good feedback to the student to improve or change the behavior. So these are the attributes you would look for in a ideal professionalism assessment. It's a tall order. It's difficult to meet all the requirements. But then, if we want to improve the quality of Indian medical graduates, we have to do it. You can't leave assessing communication or you can't leave assessing altruism or accepting mistakes simply because it takes time or it is not objective or it's of no value. Remember the phrase again, assessment wax the curriculum dark. If the student knows he is going to be assessed on these, he will learn it. If he knows ऐसे ही है, they'll just sit in the class for attendance, but make no effort to learn those particular things. And I told you there are multiple definitions of professionalism. Even medical professionalism also has multiple definitions. So, what is your priority? What are you looking for? Actually decides what and how you should be assessing. Also, remember that unlike knowledge and skill, which has standard answers, you ask anybody what is the dose of ampicillin, it will be same whether it is a medical college, a primary health center, me, you, he, she, anybody. But in professionalism, if you ask in this particular conflict, what will you do? There are generally no standard answers. Everybody will have a different answer. And most often, that answer is guided by the context. If you are working in a charitable hospital, for example, you could try to arrange some money for treatment of a child whose mother doesn't have money to pay for the treatment. But if you are working in a corporate hospital, for example, you may not be able to do it or do it partially or whatever. So context plays a lot of role. When a student sees that at the end of the day, the consultant gets an envelope from an ultrasound or CT scan center, you cannot be assessing the professionalism of the student in that situation because context makes a lot of difference. For them, it becomes an acceptable behavior. When a student enters a medical school after paying 30 lakhs or 50 lakhs for the NEET paper, then his behavior and thought process is actually changed and guided by that kind of a situation. And then there are different thresholds of unprofessional behavior. Some teachers, some clinicians who are very strict on ऐसे बोला तो बोला क्यों. And there are some who would say कोई नहीं बच्चा है सीख जाएगा. Some of you may remember the example of that resident sticking tape on the mouth of a child who was crying during lumbar puncture. Different people would do it differently. Some would say, "जी, कोई नहीं, काम तो कर दिया ना." Others might say, "Oh, how dare he? He shouldn't be a doctor." And then the issue of subjective versus objective. That's a big problem. From our school days, we have been ingrained the concept that only objective assessment is the correct assessment. And if you do a subjective assessment, then you are unfair. I think we did a session on subjectivity. So you probably would remember that subjective does not mean bias. Subjective is looking at the whole thing from a different lens. Diwar movie, I hope many of you saw. One fellow stole roti and was running, and Shashi Kapoor shot him in the leg. There was a different interpretation. The law says he should be jailed. But this police inspector felt that he was stealing only to feed his hungry family. So he needs to be helped. So he actually took out money from his purse and gave it to that person. Okay, you buy food for your family and give it to them. So it's not that one is right and one is wrong. It is only looking at the whole thing from a different perspective. And that is where we need to prepare ourselves to see different perspectives. Students might be looking at the whole thing from a totally different viewpoint, which may not be unprofessional, which may not be wrong. But we cannot have a very rigid opinion about what we have to do. And then this McNamara fallacy, I explained it last time. When you are simply after numbers, कितने पेज लिखे, कितने पेशेंट देखे, क्लास में कितनी कुर्सियां हैं, कितने एसी हैं, दैट इज योर कंसर्न। वो एसी ठंडा कर रहा है कि नहीं कर रहा, दैट इज नॉट योर कंसर्न। टीचर अच्छे से पढ़ा रहा है कि नहीं पढ़ा रहा, दैट इज नॉट योर, क्लास कितनी ली, बस वो, दैट इज आवर कंसर्न। So this counting numbers and leaving out the important information, that is something what is called McNamara fallacy. And very often, in fact, if you, uh, I don't know if I should be saying that, but if you look at the entire regulations of MCI and NMC, they are all like this, just focusing on numbers, not on the quality, not on the outcome, not on the output. So that could be another issue with assessing professionalism. And then comes even more important aspect, and that is the linkage with clinical competence. I told you earlier also, you can't be a professional without being clinically competent, and vice versa. These are the two models that I showed you. One is the model of medical professionalism, and second is the model of medical competence. Two more they have added to this, that is critical thinker and research. So these two have been added. But anyway, that doesn't make a difference. Now, if you look at these two different models, then what you would find is that a lot of things are actually interrelated. Interrelated in the sense that they come in clinical competence also, and they come in professionalism. So good communication skills is part of professionalism as much as it is a part of clinical competence. Leadership, for example, is as much a part of clinical competence as it is of professionalism, accountability, and altruism. And you can find, actually, this is only a representation. You can actually find more connections. If you add critical thinker and research activity, then probably the number of arrows would be so much that we won't be able to really make out what is happening. The point is that you cannot assess one without the other. So when you are doing a case presentation and assessing a student on a case presentation or on a OSCE, you cannot say, I am assessing only clinical skills. I will not look at communication. That doesn't happen. Cannot happen. And vice versa. When you say, I am assessing communication, and in my opinion, that is probably one of the worst things one can do is to assess communication isolated. Communication is always contextual with a specific patient on a specific problem for a specific issue. To tell postpartum mother to breastfeed her baby and to tell a postpartum mother to have a IUD inserted are entirely different things. One who can advocate breastfeeding does not necessarily know how to advocate IUD insertion. One who advocates a diabetic about importance of regular medication may not be able to do it for changing the lifestyle. These are two entirely different things. And so you cannot have isolated bits and patches of assessment. Assessment has to link clinical competence and professionalism. Without one, the other will not sustain. And then there are levels. What does it mean? Like Miller's pyramid. So knows how, shows and does. And here are some tools written for that particular level of competence. You may be surprised. In fact, some of you may question that you are assessing professionalism by MCQs, but that has to be done. Don't forget that no tool actually crosses the level of Miller's parameter. So MCQs will only tell you about knows. They will not tell you about knows how or shows or does. Conversely, self-ratings will tell you about shows, but they are no guarantee that the student knows about professionalism. So when you start assessing professionalism, you have to start from knows as well. So having a theory question on professionalism, for example, is not out of place. It's very much required. And that's what you should be doing. Now, often we are stuck with this one tool, one competency model. Simple language, if I explain, because that's very much related to this. If you have a screwdriver, it is only to tighten the screw. That's it. So if somebody asks you, how will you tighten the screw? Use a screwdriver. But can we not use a plier to tighten the screw? We can. Can we not use a hammer to really push in the screw a bit and then use something else to tighten it? So having multiple tools for a competency is what is required. Don't get stuck with only one. Knowledge, MCQ, practical OSP, psychomotor communication station, and that's it. That doesn't work. Each tool has its positives and each tool has its negatives. And when you combine tools, you compensate for that weakness. You complement the strength of the tool. It's just like cereals and pulses. One doesn't have lysine, another has good amount. So you mix the two, your diet becomes nutritious. Same thing happens with assessment. If you stick with only one tool, one competency, you would be missing out on many things. But have multiple tools for a competency, and more importantly, have a tool assess more than one competencies. Take an example. When you do a mini CX, you are looking at clinical competence, you are looking at data gathering, you are looking at communication skills, you are looking at organization, and so many other things. On the other hand, when you use mini CX, there is a small part related to professionalism. And when you take feedback from peers, there is a part on professionalism. And then when you use PMAX, I'll tell you what that is. There is a part of professionalism. So weakness of one is compensated by strength of other. And that makes your assessment holistic. That makes your assessment stronger. And this is the concept of assessment toolbox. I suggest you download this paper and go through it. It will give you a lot of ideas about what and how many tools you can combine for each type of competency. What we have done is we actually listed out various tools for the domain independent competencies. You would recall that in GMER, where the roles are given, under the roles, competencies are given. So just look at the assessment toolbox paper. You can download it easily and read about what the tool is. Then there are direct observation methods. Professionalism cannot be assessed by proxy. No, you cannot, as a professor, for example, you cannot ask your senior resident, यार वो junior वाला क्या कह रहा था? That won't be an assessment. You have to see yourself, how that person is interacting with the patient. So direct observation is actually the key to assessment of professionalism. And then there are structured methods. I'll give you examples. The advantage is that they have a good predictive utility. So if you find good professionalism in one setting, chances are that it would be there in another setting also. And all those attributes which can be picked up on single encounters. Most of the attributes of professionalism, you remember that model, Arnold and Stein model, most of them cannot be picked up on single encounters, like excellence. So one encounter will not pick excellence. You have to follow the student for a long period of time. Ethics, we cannot pick on one encounter. I remember having gone for National Board of Examinations OSCE as a external examiner, and every student they know this is a communication station. So when the moment they arrive there, Namaste ji, मेरा नाम ये है, मैं आपसे ही पूछ लूं. But when they go to next station, they forget all that. They never greet the patient. So single encounters are very fallacious and give you a lot of wrong information. Some tools which you can use for single encounters. They include Mini CX and PMAX. PMAX is Professionalism Mini Evaluation Exercise. It's just modeled on the pattern of Mini Clinical Evaluation, Mini MCX. Mini CX has if you remember the form, it has a small component of professionalism. And then there are less structured methods. Here in Mini CX and PMAX, you have a form. You have already written over there what all you should be looking. So everybody using the form would look for the same criteria. But then there could be less structured methods. The advantage is that they pick up interpersonal skills better. They are more contextual. In day-to-day practice, when the variations happen, an angry patient, an illiterate patient, a patient who doesn't understand your language, that is where you need to bring in less structured methods. And then when you want to look for multiple observations over a period of time, and then you would use these methods, which include multi-source feedback and critical incident reports. When I say multi-source feedback, it means multiple people are providing feedback about the behavior of the student. So these could be the consultants, this could be the senior residents, it could be the colleagues, it could be junior residents, it could be nursing staff, it could be ward staff, and it could be patients. The only issue with this is that you have to create a culture for this thing to be accepted. You tell a consultant that a nurse will be commenting on your interaction with patients. He'll be furious, wild. Or sometimes what happens when you ask colleagues, then it becomes a mutual admiration society. You scratch my back, I'll scratch your back. तुम मेरे बारे में अच्छा लिखना, मैं तुम्हारे बारे में अच्छा लिखूं. So actually the whole purpose then gets distorted. This is an example of mini CX form. And if you see, then one of the points which you assess is humanistic qualities or professional. And if we look at the psychometric, then at the back of the form, it's already listed what you should be looking for. So a student who is rated satisfactory would show these kind of attributes. No, this could be in varying degrees. So you can give them 4 or 5 or 6. Or a student who is always doing it beyond what is expected, he could go for 7, 8, 9. And in terms of reliability, Mini CX has a reliability of 0.78 average. But if you are doing multiple observations with multiple observers and multiple settings in multiple contexts, in fact, people have also reported a reliability as high as 0.98. which is almost close to the ideal that you would expect in such kind of a situation. The second is PMEX, and why actually it can, or rather it came out, was that real-time observation of professional behaviors is an important strategy to assess professionalism. So, like a toolbox, when you have to hit a screw or insert a screw, then you use a hammer to put the screw little aside, and then you use a screwdriver to tighten the same thing happens here. So you first use mini CX, broadly look at if the student is satisfactory, okay, he goes. But if the student is ranked 1, 2, or 3, then you subject him to a PMAX to find out in detail what are the issues where the student is actually lacking, because you have to provide feedback for improving. And in fact, if you look at, and this is, I think, 2 years old, but if you do a current search, Google search, that time I could get more than 56,000 results of PMAX being used. Now I'm sure it's going to be much more than this. So it's actually getting spread more and more and more. This is an example of a PMAX form. So actually it contains 21 statements, which was later shortened to, sorry, it contained 24 student statements, which were later shortened to 21. And here also, if you see, some of them may not be applicable in all cases. Some may be for UG, some may be for PG. And this is how you rate. Unacceptable. So this is a description. Below expectation, the descriptor meets expectation, what it implies, and exceeded expectations, what does it imply? And then there is a place to record a critical incident. Critical incident is something which is a breach of professional boundaries. You find a student accepting money from a patient. Or the example of that sticking tape I gave you. That's a critical incident. So it should be recorded so that later review, you have the documentation of all such incidents available to you. Just zoomed bit. Some of the statements which would come like listened actively to patient, showed interest in patient as a person, and so on. Let me remind you, these will be subjective, but not biased. This is your interpretation. In fact, come to think of in day-to-day life, no two people would describe a person the same way. किसी को वो अच्छा लगता है, किसी को नहीं अच्छा लगता, किसी को उसकी कुछ बात अच्छी लगती है, किसी को उसकी कुछ बात नहीं अच्छी लगती है. Same thing happens here. And same thing happens with patient. After all, whole of his life, he is not going to interact with only one patient, the standard rating. He is going to interact with multiple patients and who will view the doctor's different qualities in different ways. I elaborate a little more on PMAX because it's a new modality, not much in use till now. And these are the 4 factors which actually it assesses. So what PMAX assesses is doctor-patient relationship, interprofessional relationship, reflective skills, and time management. And you would appreciate that these are 4 very important qualities. And there are multiple reports. What is very interesting is that Ruiz et al. Decided the form in 2006. When did the factor analysis? They came out with these 4 factors. And then Bajwa et al. Repeated the study in 2021. They came out with the same 4 factors. This group from Japan, they repeated on a different population, Japanese students. They came out with the same 4 factors. So that indicates the sturdiness, robustness of the scale. That it doesn't change with change in student population or change in assessors. It probably is measuring the same thing over and over again. And interestingly, with a good sample size, you can reach a reliability of 0.99, more than mini CX. We had applied it in our institution, CMC, when I was there. So we applied PMAX in dental students. And that was one of the first studies on PMAX published from India. Now, who should be assessing is another important point. As I told you, context and institutional factors make a lot of difference. To give you an example, I think I gave it last time also, but even if it is repetition, doesn't matter. You have a 2-year-old child presenting with first episode of convulsions brought to a primary health center. The doctor examines the patient, stabilizes the patient, gives a dose of anticonvulsant, and once the child is settled, refers to a higher center for further evaluation. Totally professional behavior. Now imagine the same child going to a department of neurology in one of the tertiary care or referral hospitals, and they doing the same thing, would become totally unprofessional. They'll say, you didn't get a PET scan. You're not professional. So context and institution makes a lot of difference. And you can think of multiple examples where you would manage patients in your setting because they cannot be referred or because they don't have money to go to a higher center with a slightly suboptimal measures. But when he goes to a referral center, for example, with all the facilities, then probably he needs to do all that. In fact, I'm told that, told or other seen also, you have a patient with head injury, and unless you do a CT scan, nobody will come and see the patient. But you can't afford to do that in a, say, primary health center. So institutional factors make a lot of difference. And it should focus only on observable skills and behavior. Don't presume things. I think he meant that. I think he was trying to say that. No. What he did is actually what is required. And therefore, the role of assessor skills become important. So the assessor should know how to rate the behavior and how to grade that performance. The colleagues or peers may be useful for formative. You can think of using nurses, allied staff, patients, but again, as I said, cultural acceptability becomes an issue. Are your people willing to have feedback from nurses? Or is it that nurses will try to settle score, for example, with doctors? Or a ward boy will settle score with doctor because you didn't give him a good Diwali tip. Now, those kind of issues can crop in, and one has to be really careful before getting many people into the feedback. I showed you the levels, and I emphasize again that paper and pencil test must be used for knowledge. Knowing about professionalism is the first step to practice professionalism. Unless you know what is professionalism, you won't be able to really practice in a professional way. And workplace based assessment, assessing them right where the action is. Go to the OPD, stand there and see how they are communicating. Asking them to communicate on a OSCE station probably is not going to give you accurate information. So workplace assessment, and what has also been reported is that detection rate is higher for inpatients rather than outpatients. Maybe because you get longer period of time, you have the same patient for many encounters and many days, whereas in OPD it's a short encounter and a short time, so things are there. Then legal standing would be another issue. If we take that example of the resident putting a sticking tape on the mouth of the child, can we expel this person from the college? Will your courts allow this to happen? Or will your university allow this to happen? That is, again, moot question. Now, you pick an unprofessional behavior, but you can't do anything. So then the sanctity of whole assessment is lost. So we should be clear about what are the legal and statutory boundaries of what we do. And more importantly, what is the behavior outside the classroom? In the classroom, everybody is well behaved and well dressed and well mannered and so on. But what happens outside? So that is another issue which we need to keep in mind. Now, when it should be assessed, I think just like other things, formative, it should be integrated with the program and linked to teaching. So when you are teaching history taking, for example, also teach about communication. When you are teaching about physical examination, also teach about patient autonomy. Also teach about medical ethics. Also teach about the right of the patient to accept or deny modality of treatment. Summative, of course, that has to come at decision points. I'm not saying you put it in the university examination because again, one encounter is no encounter. But during internal assessment, for example, or during 6 monthly assessment, for example, maybe the right time to assess professionalism. You can actually do it for both purposes. Since you are not using it in the final university examination, you can use the same assessment for grading as well as for providing feedback to improve the behavior. And as far as possible, try to club it with others. So a clinical palpate the abdomen station should also have a mark for communication, and it should also have a mark for ethics. And the student should know that it is not only the technical skill which they are going to be assessed, but also on the various other skills. And the use of this data is, in fact, clear cut. You actually are trying to help the students. If you remember last time, I had said that the current focus is not on picking unprofessional behavior. Current focus is on helping the students acquire good behaviors. And that is what you can use that. You can use early detection of lapses in professionalism. It might be there for certification issues. And then be aware of the consequences of assessing profession. Your institutional culture will allow that. Judiciary, legal things, will it allow that? So be aware of this. Documentation is important. We designed this longitudinal assessment. This is a form for mini CX. So you have one per year, and each resident has a form, and you have multiple assessments. You see here date 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And we have listed 10. Last time, if you remember, I told you 6 to 8 encounters a year give you good reliability. So have multiple encounters. And for example, if you are looking at only professionalism, then you can actually chart the progression of the student. So it should be going from below expectations to exceed expectation. There might be a student who is static, below expectation, and all the assessments you are finding below expectation. Then something is wrong somewhere. Need to intervene. Or some student who initially started with meets the expectation and now suddenly coming to below expectation. Again, those deviations you need to pick up. Ruzi is there. So thank you, Ruzi, for designing this particular form. And it can be used for multiple attributes. Not only professionalism, you can also use it for various other areas of critical competence. So what I want you to remember is that professionalism is a multi-dimensional concept which must be assessed for it to be learned. Second, no single tool can measure all aspects of professionalism. You have to use an assessment toolbox. Remember that often said line, more tests, more tools, more context, more assessors. Will improve validity, will improve reliability, will improve educational impact. And have a concurrent mentoring program with appropriate guidance and remediation. Just assessing and saying, oh, you don't know, is not enough. You have to guide the student to change the behavior. You have to guide the student to modify the behavior. So, what questions you have? No questions.
Very important. Especially in both assessment, as you say, we will not assess, but then the student will not learn.
You teach them all about that com, and then at the end you ignore bad communication. Then they also know it is for McNamara fallacy is a big problem.
Actually, in our schools, what used to happen, we used to get a report card, and I think after 6 months, we used to have parents-teacher meet, and our teachers used to assess us like for courtesy, for our concentration, how we had the behavior with others, we you like the mini CX you showed us here. We used to have it in a school time in our report cards. I think I'm still having that report cards with me here. The concentration is there, then high or medium or moderate, something like that. So I think basically this is for the medical college's purpose. But since we are the part of the paramedical college, so we need a such type of assessment form either in this means or by that means to be assessed for assessing our students also. So I think this should be implemented in our college also, so the same thing. तो copy करना है आपको इसलिए बुलाया है।
I just want to add here that we actually did a multi-centric study. We involved 20 medical colleges across the India, and there each college used this PMAX form to assess professionalism for at least 100 students per college. So we had a fairly big size data, almost 800 students or so. We are in the process of analyzing it, and our aim is to actually try to reduce the number of items in that list, because even assessing 21 items become a problem. So if we could cut it down to say 5 or 7 and still maintain that reliability, I think it will become more easy, convenient, and useful for everybody's work.
Definitely, definitely. For purpose of organizing this and calling the other health professionals like from paramedical college, you are from MBA college. Okay, because these are not related to only MBBS or MD, MS courses. These can be applicable for because these are paramedical, no? These are MSc students. They are dealing with operation theater technology or imaging technology. So they are also dealing with the patients. Yes, sir. Similar, it's a similar. They should also have this good communication skills. Same way you can apply. It's very important, I think, professionalism for them because patient directly don't go to the doctor because patient have to get some X-ray, some CT scan. They go to the them and initially they deal with the patients.
No, no, and actually they have an important role to play. For example, I refer a patient for CT scan, and then one of them says, "उधर चले जाओ, वहाँ पे ज़्यादा अच्छा होता है." No, it's a problem. और somebody says, "इसकी तो जरूरत नहीं थी, डॉक्टर साहब ने ऐसे ही कर दिया अपनी कमीशन बनाने के लिए." Then there's a problem. So everybody is important in that team, and everybody has to play a very important role for this. Yes, Sushant, you wanted to say something?
Yes, sir. I'm Dr. Lavanya. I was also attending the webinar with Sushant sir. Sir,
हाँ,
I'm professor in community medicine in his department only.
हाँ जी.
And I had a question, sir. Like, I have come across many scales to assess attitudes and professionalism, but
Hmm.
many of the attributes are overlapping. How do we demarcate the attributes for attitudes and professionalism?
No, I don't think we really need to demarcate, because human behavior, good human behavior is a complex issue and a complex process. So it's very difficult to really say this is here one ends and this is where the second starts. So some overlap would always be there. When you say communication, for example, then communication also means humanism, some
Yes, sir.
element. And then communication also means clinical competence. See, when
Yes,
you
sir.
have to tell about the line of treatment or when you have to tell about prognosis, you have to first know about the prognosis before you can actually tell to the patient. So there would be a lot of interlap. And if you had seen those two diagrams of professionalism and Indian medical graduate, and then lot of linkages that I showed, was
Yes, sir.
actually for this purpose that you don't have isolated standalone entities. These are all interlinked to each other.
Okay, sir. Okay. Thank you, sir. Thank you very much.
Anybody else from online group?
So may I ask a question?
Sure, sure.
So while using the SPMX practically, there was one aspect which studies not only their behavior with patients, but the behavior with their colleagues, the peers, how they are interacting and whether they're helping them out. This practically I was finding it difficult because per se our presence there while they are taking bedside histories modifies their behavior with the patients. And once we are there, then their behavior with peers is completely formal and something which is very difficult to assess and comment upon. So this aspect I was finding very difficult how to create that environment where you can assess their inter peer behavior as well.
So, Ruzi, you actually echoed what we heard a little while ago, that there is a lot of overlap between things. And you also strengthened my assertion that one tool may not be enough. So, for example, PMAX alone may not be enough for everything. So, you have to supplement PMAX with, for example, multi-source feedback. In fact, I'm sure all of us who have been through residency would tell you that the best place to know about the real qualities and character of a person is the duty room. You know,
Right.
that is where it comes out in its true form. In the ward, it's all doctored. Either because of the patients, you shouldn't be saying, ideally, you shouldn't be saying, or because of consultants, or because of nurses, or because of security cameras put all around, which are capturing your behavior. So, that's modified. But again, the point is that even if you are able to force a person to behave in a certain way over a period of time, the chances are that this would become a part of the behavioral process.
Right.
So ultimately, it helps. And since as of now, and maybe over next 25 years or so, we are not going to use professionalism for summative assessment. Most of it is going to be formative. So I would be okay, even if there is some inaccuracy, for example, some lack of validity, some lack of reliability, that doesn't matter.
Right.
The very fact that the student is getting assessed, the student knows that he is getting assessed, and a mentor or a teacher is giving feedback on how to modify the behavior, I would be happy.
Right.
Even if it is not really, totally flawless, impeccable kind of assessment, I don't mind that.
Right. Thank you.
Sir, may I ask another question, please?
Gee, please.
Sir, how trustworthy is objective assessment? Because different people perceive same behavior differently. So, how much can we trust the objective assessment also?
I, I don't know if you have read about mini CX,
Yes, sir.
but if you have, then this subjectivity or different people giving different kind of ratings is actually considered a strength of mini CX,
Okay, sir.
because that it allows you to see yourself all around.
Okay.
With objective, you look only at one angle and somebody says your hair are very nice. But when somebody looks you around, 360 degree,
Yes, sir. Okay.
then you get a true picture of what you look like. So same is true with these subjective elements. And please don't forget that in a clinical area where there are multiple units, multiple consultants, multiple people, multiple type of patients, the behavior has to change to suit the context.
Yes, sir.
The way you talked with a PhD mother would be very different from the way you talk with a illiterate mother from a rural area to explain the concept of lifestyle changes, for example. So that is the importance of having multiple. The keyword here is multiple. Not that you have only one assessment subjective and then over, not that way. Have multiple. When I say 8 assessments or 10 assessments, it is with this purpose only. I'll give you another simple example. When you have students in your class, most of the teachers rate the students mentally. ये बहुत अच्छा है, ये distinction लाएगा, ये ठीक है, पास हो जाएगा. This fellow, he has a problem. Now, every teacher assesses the students like this. It's not based on any marks. It's based on your day-to-day observation of that student. How is he interacting in the class? How is he participating in the small group discussions and so on and so on? And this is a subjective assessment. Tell me, how many times have you gone wrong in your assessment of the student? Hardly.
Yes, sir.
Most of the times when we predict about a student, when you say it's a very good student, two people might differ on whether he would get 75 marks or he would get 80 marks. That is okay, acceptable. But both of them will say that he will outperform everybody else and score very high. That is what assessment of professionalism is all about. You don't really have to bother about whether he will get 60 or 62. But you have to bother about whether he will demonstrate acceptable behavior or not demonstrate acceptable.
Thank you very much, sir. Thank you.
Why don't you join our program on assessment?
Sir, actually, I'm pursuing PhD. I'm in third year now. I cannot join any other course.
Yeah, so keep it in mind.
Yes, sir.
I
Yes, sir.
think it will
Sure.
give you a lot of new ideas and vision to
Sure,
look at the assessment from a totally different perspective.
sure, sir. Thank you, sir.
Okay, so thank you very much. And next session we will have on Monday. And this Monday, I'm going to talk about one of the most neglected and ignored, but extremely useful and important area for competency-based curriculum, and that is reflections. So I suggest you encourage your departmental or institutional colleagues to join if they can, because reflection is something which is in everybody's domain. Everybody of us wants the students to write and assess reflections, but we don't do it because of many misconceptions and many other shortcomings which are surrounding it. So see if you can motivate more people to come and listen. So thank you very much and see you next Monday.
Not bad.